This is going to be a whirlwind trip down substance abuse lane. We're going to do it rather fast because to give you an overview of what is important. There are about 20 to 30 slides towards the end of your package about co-occurring conditions, which I think are going to be covered with other topics. So I'm including them in your package more for completion rather than to go over them. So there are about 30 less slides we'll go over than show up on my presentation today. So if I skip over them, that is by design and intention. Which of the following is not a DSM-4 diagnosis? Alcohol-induced persistent amnestic disorder, polysubstance abuse, hallucinogen-induced psychosis, and caffeine intoxication. The correct answer, those of you who got it, is polysubstance abuse. Okay? A lot of people got caffeine intoxication. That is actually a DSM diagnosis. Next one, please. Life-threatening withdrawal symptoms can occur with which one of the following? PCP, Demerol or meperidine, alcohol, or LSD. And most of people got it right. That's correct. Absolutely correct. So let's get started about substance use. I am on a speakers bureau for Reckitt Benckiser and Pfizer, and I am not discussing any of those products. We will start with alcohol and basic concepts about what lies at the heart of addiction. If you look at it, there are DSM criteria for opioid dependence, and I have simplified these criteria for your convenience. There are 3 out of 7 criteria required. More needed with diminished effects, withdrawal, or the drug is used to prevent withdrawal. There is more of the drug ingested than intended. There are unsuccessful attempts to cut back or to control. There's much time spent in getting high and seeking the drug and recovering from the drug. Lots of social occupational activities are given up and continued use despite knowledge of harm. I'll simplify this concept for you because if you look at criteria number 3 and 4, more ingested than intended and unsuccessful attempts to cut back, is that nothing more than just the loss of control restated in 2 different ways, right? So if you would scratch that out and just scribble loss of control, you'll get it that we are really simplifying and getting to the heart of the matter. If you look at criteria 5 and 6, a lot of time is spent using the drug and you're giving up activities to compulsively use the drug is nothing more than compulsive use. There are 2 different criteria devoted to just define that relationship which is characterized by compulsive use. So the criteria 5 and 6 is compulsive use, and the last criteria is consequences. So there you have it. You have tolerance withdrawal really being explained as the physiological dependence by one set of criteria. Then you have loss of control, compulsive use, and consequences. And everything else gets distilled into those concepts. And if you simplify it further, and I propose to you that what is compulsive use and use despite consequences, if nothing more than loss of control restated. So there you have it. There's really 2 criteria for substance use, out of which loss of control accounts for 5 of them. And everything else is just restated again and again and again, somewhat redundantly. So when you're clinically trying to interview your patients and trying to look for criteria, if you explore this relationship with your patient and you find loss of control, you have the diagnosis. Because there are 5 different ways of stating the same phenomena. And I would submit to you that the next criteria, that the next concept, physical dependence, often follows this loss of control and is not primary. So it is unfortunate that we use the word dependence in substance dependence. I actually prefer the word addiction because it really talks to this loss of control. And people get needlessly confused, and people wait for physical dependence to occur to begin to think, you cannot be dependent if you don't have physical dependence. And that is a complete misnomer. And this slide is really there to help you understand that you do not require physical dependence to be dependent as DSM describes it or as addiction really intends to be. And often dependence is a consequence of the loss of control, which to me is a primary concept of addiction. Right? And then you have another concept that is the concept of drug abuse. What is drug abuse? An abuse of drug is really that you're using the drug in a dysfunctional way, as manifested by 7, 8 different criteria, but it doesn't matter. The relationship between you and the drug has become dysfunctional. It's beginning to cause consequences. If you have 2 such things occurring within a 12-month period, you meet criteria for drug abuse. Having defined and simplified the concepts of addiction, let's go and tackle individual families of drugs. What drugs are likely to be abused? What makes a drug and what predicts the abuse liability of the drug. Number one, it has to get into the brain, right? Once it gets into the brain, it needs to cause euphoria once it gets into the brain. So it has to get into the brain reward pathway and release dopamine inside the brain reward pathway. The clinical manifestations is euphoria. Euphoria drives repeat use. Once you try and use the drug repeatedly, you want a drug that has a short onset of action, because you don't want to use a drug today and it hits you in church on Sunday. You want to hit it right now. And that is the whole purpose, that you want a short onset of action. And again, a drug that's more likely to be abused is the one that has a short half-life. Now, the two of them, short onset of action, short half-life, lead to repeated administration, which accelerates neuroadaptation. The more frequently you administer a drug, the more likely you are going to get adapted to it. So these are sister phenomena that lead to predicting abuse liability. And then, of course, you want to get drug into the brain faster. So anything that hastens the way drugs get delivered, it is the best way. If you find a way to deliver drugs into the brain faster, that form of delivery is preferred of the other forms of delivery. That's why intravenous drugs might be preferred before oral drugs, et cetera, et cetera. And then, of course, you want to have a drug that preferably has fewer side effects. If the predominant effect of the drug is death, then that drug is not likely to be abused. Let's switch to alcohol, the most commonly used drug that we are going to be talking about. A little bit about the pharmacokinetics and pharmacology of alcohol. Predominant site of absorption is in the first part of the gut, stomach and the duodenum. And the concentration, the blood alcohol concentration, obviously depends upon what you drink, how quickly you drink, what is the concentration, but also upon whether there's carbonation. Why does champagne hit you faster than white wine, although they are preferable same amount of alcohol? It's because the interface of absorption gets increased because of those small bubbles, and it hits you faster. Presence of food, which will delay the absorption, gastric emptying time, gastric metabolism, and of course the first pass metabolism in the liver. All of these are the various phenomena that will predict what is going to be the blood alcohol level with whatever time point you're looking at. Alcohol is very interesting because if you look at the alcohol metabolism, you see that alcohol is metabolized predominantly in the liver. Okay? Alcohol is converted from alcohol to acetaldehyde by alcohol dehydrogenase. Now, which of these products is more toxic, alcohol or acetaldehyde? Right? It's a sister drug to formaldehyde, the drug that we don't like. So again, if you if you look at it logically, it tells you which is the rate-limiting step. The rate-limiting step is the first one. The first one, the entry into acetaldehyde. We are really very good at getting rid of the acetaldehyde. It is the first step of what enters into the pathway, which is limited by the first step. And because alcohol dehydrogenase is rate-limiting, the amount of alcohol that is processed by the liver is also limited. So that is why the metabolism of alcohol is subjected to really the zero-order kinetics. There's only a fixed amount being metabolized. It's not a fixed proportion, but a fixed amount. So whether you have 10 drinks in the first hour or 1 drink in the first hour, the amount your liver is going to get rid of is only 1 drink in that first hour. Okay? And that really is very helpful because it helps you very easily clinically to predict what is going to be the intoxication amount, you can predict what is the blood alcohol level, which allows people to infer if your blood alcohol is X now, how many drinks you had 3 hours ago, et cetera, et cetera. Acetaldehyde is a toxic compound, and this is the compound that if it accumulates in the system is when you're going to have serious side effects from alcohol intoxication. And obviously, the liver, being the wonderful benevolent organ it is, has plenty of enzymes to get rid of this toxic compound.